Assalamu alaikum and a very good morning to all the participants who have joined. And I would like to thank Pakistan Academy of Neurological Surgery, especially Dr. Athar Naam, for giving me this platform to teach. So why I chose non-neoplastic brain lesions is the fact because a wide variety of non-neoplastic lesions mimic brain tumors, both clinically as well as radiologically. Representing a potential pitfall for the treating physicians and surgeons. So just to make things clearer, I found it very challenging and new topic. So there are a few ground rules. I've tried to make it interactive. So pull your smartphones to access the poll at menti.com. There will be a leaderboard to make it more exciting. Snapshots are prohibited. Oh, it's just to save your phone memory because the entire presentation will be recorded and will be available on web. Am I right? So stay tuned till the end as feedback matters. So I have a disclaimer. I'm a full-time salaried faculty at AKU and I have no financial interest or conflict of interest to disclose for this presentation. The entire material is for teaching and knowledge purpose, and most of the cases I've pulled from my department, though a few of them are taken from the web and published literature with appropriate references. And I must confess, I love neuroimaging. So here we have a poll. You can join on your phone and type menti.com and this code 47730708. So we can see that these are the objectives of the presentation. I don't want to repeat them again, and we can have a live question answer sessions. So as we know that everything that shines is not gold, similarly, every space occupying lesion in brain is not a tumor. So as rightly quoted by John Hopkins, all tumors are lesions, but not all lesions are tumors. So here is a long list of mimickers of brain tumor, but we can only master a few in this limited session. Here the list goes on. It's the infection that may mimic a tumor. It can be a demyelinating process. It can be an intracranial hemorrhage or ischemic stroke. It can represent neuronal migration or cortical malformation disorders. Any vascular malformation may present like a tumor. Post-treatment radiation necrosis is also a mimicker, and similarly, vasculitis or meningitis may present as a tumor. So one should follow a basic algorithm whenever you are diagnosing a lesion within the brain. And so whenever the patient is coming from ER or clinic, the first line of imaging is mostly an unenhanced CT scan. So if you see a hyperdense or hyperdense lesion within the brain or with or without edema, you should consider a variety of diagnoses. It can be neoplastic, and again, it can be non-neoplastic. To further characterize, one should embark on the second line of imaging, that is an enhanced MRI brain. And mostly the conventional imaging is enough to come to a reasonable diagnosis, but at times even the radiologist is stuck. So we move on to further advanced or functional imaging such as MR spectroscopy or MR perfusion. At times when we are thinking in terms of demyelination, a contrast enhanced MRI whole spine may also help. So this is the one side of the coin, the radiological aspect. The other important side of the coin or the limb is your collaboration with your neurology and neurosurgery team, because they will give you the exact picture, the clinical picture, the background, what the physical examination is all about, so that you can avoid misinterpretation and you can direct the patient or transfer the patient under the required services and direct them to the proper management. So this is a protocol which was proposed by Savlani et al. In 2020, and according to them, they did a multi-parametric MRI in all the patients who had space-occupying lesion. They included T2 weighted sequences, FLAIR 3D sagittal sequence, DWI, dynamic susceptibility contrast perfusion imaging, post-contrast T1 3D MP-RAGE, and spectroscopy. So this is how the protocol looks like. But unfortunately, all the advanced imaging is not easily available everywhere. So the use is very limited and it has some financial constraints as well. So just a revision of the important sequences. This is a T2 weighted sequence in which you can see that the CSF is bright, and it is the best sequence, I think, which I will pull up first just to look at any abnormality, because the abnormality shines on a T2 weighted sequence. Then on T1 weighted sequence, the CSF is dark, while the white matter is bright and gray matter is dark again. And this is the best sequence to assess anatomical structures. This is a post-contrast sequence in which you can see that the choroid plexus are nicely enhancing. So any vascular lesion will shine or will be bright on this sequence. A very important sequence, DWI, diffusion weighted imaging, in which you can see it is very similar to FLAIR, and it is very good to pick up any underlying cytotoxic edema, especially in stroke imaging. But other lesions such as abscess, which show restricted diffusion, can also be bright on DWI. Similarly, any tumor which is very dense will appear bright on DWI. To confirm that the diffusion is true or not, we need to have a look at the ADC mapping, which looks very similar to T2. And if you see any bright signal on DWI, always correlate on ADC. It should give you the corresponding dark signals. Last but not the least, this is an SWI sequence, a very important sequence, because it highlights any underlying hemorrhage, iron, manganese, magnesium, calcium. And so it's a very good for vascular imaging as well, especially venous anomalies or vascular malformations. So always look at SWI. It is a very, previously we used to use a T2 GRE sequence for that. So now coming to our case one, this is a 30-year-old gentleman, known diabetic, came to ER with headache and right-sided weakness. So if you can see the code on your phone, or you have joined, players can join in. Okay, good. I can see them joining. Only one person have joined. Okay, good.
I think the rest are joining shortly.
All right. So we'll wait a few seconds. All right, so the poll has begun. You need to answer as fast. The faster will get more points. You have 30 seconds to answer.
I think it's an interesting way of learning.
I hope it was, because this is the first time using this software, so I was a bit afraid, probably using it on Zoom. All right. So I think most of you know what the answer is. So what am I doing here? All right. So very good. Excellent. So
I think it was just a start, and आपने आसान सवाल फेंका.
exactly. So just for the explanation, I just want to explain you this case. Here you can see that on top left, this is a T1 weighted sequence in which you can see a well-defined hypo-intense lesion with a hyper-intense rim and surrounding vasogenic edema. In the second image on T2, you can see that the lesion appears bright, well circumscribed with a hyperintense rim and surrounding vasogenic edema. And on post contrast, it is showing smooth, homogeneous enhancement, rim enhancement. But the hallmark feature here is the central diffusion restriction, which you can see on DWI and corresponding dropout on ADC mapping. So this is very typical of abscess. If you look at T2, you can see very subtle, thin, hypointense septi within it as well. So these are concentric rings within the abscess, which you may find um, during reviewing the images. So here is a companion case. This is a 30-year-old male on hemodialysis who presented to ER with left-sided weakness and drowsiness. He was a known hypertensive with end-stage renal disease. So again, here you can see that this is a departmental case in which you can see that there is a well-circumscribed lesion on T2, which is bright with a hyper-intense rim and significant surrounding vasogenic edema, showing subtle T1 hyper-intense rim on T1 and then post-contrast enhancement. On DWI, we can see that it is showing diffusion restriction, but it's still not complete in the center. But anyhow, the restriction is central with the ADC dropout. And if you look at spectroscopy, there is a large lactate peak indicating anaerobic glycolysis. And we see only very subtle rise of choline, which is, if you look at the y-axis, it is just reaching 0.5. So this is indicative of an abscess. So after 2 weeks, this patient again underwent a scan, and we can see that the edema has settled secondary to treatment, but now we can very well visualize the central diffusion restriction within the abscess with signal dropout and ADC. And one important feature, which is again very a hallmark feature, is the hyperintense rim on SWI. So the pathophysiology is that the abscess starts from the brain surface. When the bacteria attacks the brain surface, then there is a host reaction in which the inflammatory cells come in, and then they result in focal brain necrosis. And over time, around after late cerebritis, this turns into an abscess. And within 2 weeks, it forms a well-circumscribed collagenous or fibrous wall. So this wall is created by macrophages, which release hydroxyl or free radicals. And these free radicals are paramagnetic in nature. That's why you see this hypointense rim on SWI, similarly hypointense rim on T2H sequence. So the same patient presented after 8 months with slurring of speech, vertigo for 3 to 4 days, and left-sided headache. So now you can see that the previous abscess is still there. It has slightly grown in size, but now you can see that there are multiple confluent abscesses within the posterior fossa in the left cerebellum, again showing central diffusion restriction with dropout and rim enhancement. So how nicely you can differentiate it from tumor. So the hallmark features include, as I've already told, central diffusion restriction, T1 hyperintense rim, T2 hypointense rim with central concentric septi, and enhancing rim, which is very smooth and homogeneous. It is not nodular. Just to differentiate it from metastases, here you can see in first look, you will say it may be an abscess, but it's a rim enhancing lesion. And if you look at it carefully, the T2 has a hypointense rim similar to abscess with vasogenic edema. And it also has a smooth rim enhancement, just as we saw in the previous case. But it is not showing susceptibility or hypointense rim on SWI. And if you look at DWI, there is no central diffusion restriction. In fact, it is showing rim diffusion restriction and dropout on ADC. So this is how you differentiate it from any other ring enhancing lesion. Now coming to case 2.
Dr. Shan, sorry, I have a question.
Ji.
So the scan you just showed is quite similar with the one in which the abscess was in initial state. Am I right?
Yes.
So yes. How to differentiate between these two exactly?
By clinical history. If you have a good clinical history, then you will, and it depends, because most of the cavity was not filled. It was only partly left in the center. So that's why, and based on that, and based on SWI findings, the hypointense rim and the typical hypointense rim on T2, we can identify abscess. And
that is characteristic of abscess, but not of
metastasis,
right?
Yes, not mets.
Thank you.
All right, so moving on to our case 2, there are this is a 36-year-old gentleman with history of maxillofacial fungal infection 10 years back and left orbital enucleation. He presented to ER with headache and altered level of consciousness. So initially, he underwent a CT scan in which you can see that there is an ill-defined hyper-dense lesion in the bifrontal region, which is occupying the corpus callosum, and it is causing compression of the foramen of Monro and compressive dilatation of the lateral ventricle on the left side. There is significant vasogenic edema. And though the basal cisterns are patent, so of course, the first thing comes in mind is a tumor. So for further characterization, we move on to NMR. So this patient underwent a biopsy and a shunt placement for the hydrocephalus. And now on T2, you can see that there is an ill-defined hypointense lesion, which is associated with significant surrounding edema. So if you keep tumor in mind, then mostly the tumors are bright on T2, but this lesion is significantly hyperintense on T2. And if you look at T1, it appears relatively bright, even brighter than the white matter. So the presence of iron, magnesium, or manganese within the fungal hyphae leads to this bright signal. And on post-contrast, you can see that it is showing heterogeneous post-contrast enhancement. On DWI, again, it is not showing any diffusion restriction, but this is not a rule. It may show diffusion restriction depending on the type of fungal infection. And here, another at the next level of DWI, we can see that there is a focal hyperintense area in the left cerebral peduncle, which is indicative of a infarct. So this can be a vasculitic infarct. On SWI, again, it is showing susceptibility. So the overall picture is that of an invasive fungal infection rather than a tumor. And this is a biopsy proven invasive aspergillosis. Case 3, 9-year-old boy. This is a very recent case I've seen, and he presented to ER with acute history of headache and vomiting. So here you can see that on a T2 weighted sequence, there are bilateral symmetrical hyperintense signals in bilateral cerebral hemispheres, and you see that it is very edematous with the effacement of the folia. And on corresponding T1, it is showing dropout. It is showing very low hyperintense on T1. On T1 post contrast, there's a lot of phase encoding artifacts, so like we are unable to appreciate the underlying abnormality. But on moving on to DWI, there is some bright signal which is not showing any dropout on corresponding ADC, which is indicative of that there is no true diffusion restriction within the lesion. On post-contrast volume sequences, sagittal image, you can see that there is a lot of edema within cerebellum, which is resulting in effacement of the basal cisterns. And you can also see some leptomeningeal enhancement within this region. There's complete effacement of the fourth ventricle, and there's definitely proximal hydrocephalus with some with impending tonsillar herniation. So this is the case of acute cerebellitis. And to differentiate it from an infarct, it is you have to look at the DWI sequence because there is no true diffusion restriction. And the symmetry is also indicative of underlying infective/inflammatory process. And there are variable causes of having acute cerebellitis. It can be infectious, it can be systemic infections like varicella zoster or typhoid, malaria, and a long list. So especially in a child, you should be thinking of an infective/inflammatory process rather than a tumor. Now coming to case 4, this is a 41-year-old male who presented with complaint of right lower limb numbness for 3 weeks and right lower limb weakness for 2 weeks. So I will project the case now. Those who have not joined can join in. Fatma, I cannot see the code. If you can.
So the code is 47730708.
All right, so you can go to menti.com and it's 4770
0708.
0708. So here's the question. All right, so most of them know okay, what this lesion is. That's great. So this is a demyelinating lesion.
That was a trick question, by the way.
All right, so let me explain. This is a T2 sequence on the top left, and you can see that there's a focal bright lesion in centrum semiovale, which is centered within the white matter, and it is showing subtle hypointense signal on T1 and very subtle patchy enhancement on a post-contrast sequence. If you look at DWI, it is bright on DWI, but there is no corresponding dropout on ADC. And in a sagittal image, you can see that it is involving the white matter predominantly. So considering its location involving the white matter and no diffusion restriction with subtle patchy enhancement, one should think of a demyelinating lesion rather than a tumor. So patient, again, when once you know you're thinking of a demyelinating lesion, then you should correlate it clinically and with lab workup. So this patient had raised CSF proteins and oligoconal bands were matching in CSF and system and serum. So that was indicative of underlying systemic infection or autoimmune process or any paraneoplastic process. So this was not a true MS, multiple sclerosis. This was secondary to underlying systemic disorder. But here I would like to show you a companion case in which you can see that these are again well-defined hyperintense lesions in bilateral centrum semi-ovale. And on FLAIR, you can see that it is also showing some necrosis in the center, showing FLAIR suppression. And on T1, you can see that it is showing incomplete rim enhancement. This is called the leading edge enhancement, and this is very typical of demyelination. So again, this is called a tumefactive multiple sclerosis because it has a leading edge enhancement, and this is very typical or hallmark feature of this lesion. Again, you can take help of MRS, but it is very non-specific. It will appear very similar to tumor, showing a large choline peak and actate peak. But um, you can also have some other TE or short TE MRS to see at glutamine and glutamate peaks, but again, it is very non-specific. So mostly the conventional imaging is very helpful. So we know that there is a spectrum of demyelinating disorders in which everybody is aware of MS, and there is also a few other entities like neuromyelitis optica, ADEM, and the newly recognized MOGAD disease. So here is an example of MS in which you can see this is a FLAIR, a sagittal sequence, and you can very well appreciate these Dawson fingers, which are perpendicular to the septocallosal angle, and these lesions can also be found in subcortical white matter involving the U fiber and in the dorsal brainstem in the infratentorial lesion as well as in the entire spine. If active, they will show contrast enhancement. This is an example of ADEM in which you can see multiple lesions, looks like very much looks like a tumor or metastases, but these are actually demyelinating lesions which are involving the gray as well as white matter. This is a monophasic disease, and it improves with treatment. Mostly it is post-infectious in nature. This is an example of neuromyelitis optica. So as the name indicates, it involves the optic nerve as well as the spine, in which you can see that there is some bright signals within the left optic nerve, and there is enhancement in the left optic nerve as well. And if you look at the spine, there is longitudinally extensive myelitis of the cervical cord, and it is also showing subtle patchy enhancement. So again, keeping in view the entire spectrum, it is a demyelinating disorder and not a tumor. This is an example of a MOGAD disease. MOGAD disease has presentation similar to ADEM when it presents in children or population, and it behaves similar to NMO when occurring in adults. So here you can see that on FLAIR, you can the white matter is involved. There are multiple white matter lesions as well as deep gray matter is also involved, and there is some hyperintense signals in the right optic nerve and the perioptic nerve sheath. So this is a case of MOGAD. Now coming to our case 5, this is a 5-year-old gentleman presenting to ER with headache and generalized tonic-clonic seizures. So I want all of you to join the poll. All right, great. So most of them know what this is. This is a venous infarct. So let me explain you. This is here we can see on T2, there are very symmetrical hyperintense signals in the bilateral parietal lobes. We can see this gyral edema involvement of the cortex and subcortical white matter. We can also see some low signals on the right side. These lesions appear low on corresponding T1 and subtle bright signal here is indicative of hemorrhage. On post-contrast, we can see there is a lot of leptomeningeal enhancement. Basically, this is congestion secondary to venous sinus thrombosis. So we can see a lot of collaterals over here. On FLAIR, we can see that there are bilateral symmetrical hyperintense areas. On post-contrast FLAIR, again, you can see there's some congestion and edema. And on corresponding SWI, we can see that there is dropout in these regions indicative of hemorrhage. So the catch point is there, the lesion is very symmetrical and bilateral. And whenever you have in mind that there is some venous obstruction of thrombosis, always look at T2. So on T2, you can see that there is loss of flow void in the superior sagittal sinus where my arrow is. And similarly, it appears bright on T1, though it should show a delta sign nicely, but not shown on over here. And on FLAIR, you can see again that there is loss of flow void in the right transverse sinus. So you can easily make out that there is underlying venous thrombosis. And of course, there is blooming of this thrombus within the SWI sequence. To further confirm our findings, we can do an MRV, a contrast enhanced MRV, in which you can see that there is definitely a filling defect in the right transverse sinus reaching up to the tortula. And here in the superior sagittal sinus, this is all thrombus because this is a contrast enhanced sequence and these sinuses should shine or should fill with contrast nicely. So this is definitely a CVST. This is a case of a 47-year-old gentleman who presented to ER with confusion, slurring, and speech disorder for 4 hours. And he had been having intermittent headaches for past 2 months with migraine like headaches probably. And no, it was he was treated for non-complicated dengue fever 1 month back. So this is a very interesting case. So I thought I should share. On T2, you can see that there is some hyperintense signals in the left frontal lobe around the Sylvan fissure, and it appears hyperintense on T1. And if you look at post contrast, it is showing a subtle patchy post contrast enhancement. On DWI, we do not see any significant bright signals or dropout, but on SWI, we do see some susceptibility. And if you look carefully, there is a tubular structure which is also showing dropout. After 2 days, this patient had hemorrhage, and you can see the amount of hemorrhage with perifocal edema. And so the thought process was that of an underlying tumor. So the patient underwent evacuation of this bleed to find out any underlying tumor. So I'm not disclosing the histopathology right now. And for the patient then came for follow-up after 8 months. And here you can see that there's an area of encephalomalacia and gliosis on T2 and similar findings on FLAIR sequences. And you see a lot of susceptibility on SWI. But if you look carefully at post-contrast T1, there is a focal enhancement which has a branching pattern. So this is very typical of a developmental venous anomaly. This is called caput medusae sign. And there have been case reports in which DVA is associated with the thrombosis of the draining vein. So probably this DVA associated with a cortical vein, which was thrombosed, and this has led to the hemorrhage. So uh, whenever there is a bleed, always think of variable causes, not only underlying tumor, it can be a vascular malformation as well. So another case, 44-year-old female came to ER with presenting complaint of left upper limb weakness and slurring of speech for 1 day, associated with left sided facial weakness. It resolved in 15 to 20 minutes, and there was no vomiting, headache, stiffness of neck, or loss of consciousness. So now you can see that there on T2, we can see multiple low signal areas, which are very serpiginous and tubular with focal areas of dilatation. And on T1 also, these appear very low. On post-contrast, these are showing again tubular enhancement. On DWI, we do not see any restriction within them. But on SWI, these are visible as a vascular bunch of vascular area. And on a post-contrast MR examination, you can see how nicely this is a large bunch of vascular malformation. So this is an AVM. So it may present like a tumor and look like a tumor. But again, the signal characteristics is not that typical of tumor. So these serpiginous tubular structures are indicative of a malformation. Coming to case 8, this is a 4-year-old boy who presented to clinic with medically refractory epilepsy for 2 years. Parents also complained of poor social interaction, delayed speech, and developmental milestones. So now we have a question. So you can join. All right. So most of them know what the answer is. Very rightly said. This is a focal cortical dysplasia. So to explain this, we see that there is a hyperintense signal on T2, which is involving the cortex as well as the subcortical white matter. So blurring of the gray white matter interface. And it is bright on T2 and low on T1. And there is bright signal on flare as well with no diffusion restriction. And it is not showing any post-contrast enhancement. So again, it is very different from tumor, but again, you cannot exclude a low-grade glioma in this case. Then this is a companion case, and let me point out that this is a biopsy-proven focal cortical dysplasia. This is a companion case in which you can see that there is a lesion in the right frontal lobe, which is again low on T1, and it is not showing any post-contrast enhancement, and there is no diffusion restriction within the lesion. So this is also a case of focal cortical dysplasia. So I'll skip this one. I'll move to another case because we are left at only 15 minutes. And this is a 60-year-old man with known hypertensive and diabetic presented to ER with left-sided weakness. And here you can see that the brain looks very bad. It seems like it's a tumor. There is a lesion in the right temporal lobe, which is bright on flare. And if you look at DWI, it is showing intense bright signals with dropout on ADC. So this is an acute infarction in right MCA territory. And if you look on the contralateral side, again, this also looks very bad. This is all encephalomalacia and gliosis due to previous infarct, and this is all loss of volume. So in cases of infarcts, you need to look at MRA examination, and here you can see that there's complete occlusion of the MCA. 65-year-old male presented with headache in OPD, and this, I will walk you through this case so that you can answer. After this case, we can have a poll. This is a T2-weighted sequence. Here you can see multiple well-defined conglomerate hyperintense lesions which appear low on T1. They are not showing any post-contrast enhancement. On FLAIR, we can see some hyperintensity around them. On DWI, there is no diffusion restriction, and it appears bright on ADC as well. So now you can poll and join. So here I have not given you any option. You need to type it down. I don't see any answer coming in. Please answer fast. All right, so at least we have two answers. So the answer is perivascular space, BR spaces. Okay, we got two answers of old infarct and cavernoma. Okay, very similar to old infarct, I agree. But basically, what we see is that it is following CSF signals on all sequences. And since it is very conglomerate, and this is the typical area where VR spaces can occur, so these are tumefactive perivascular spaces occurring over here. So here is a companion case just to show that there is a lesion in on T2, which is bright, and it is low on flare sequence, and it is showing surrounding some edema and gliosis as well. It is not showing any post-contrast enhancement, and of course, it is not showing diffusion restriction as well. So these perivascular spaces can behave as tumefactive perivascular spaces, mimicking any cystic tumor, and so one should be careful of them, and just have a look on them in all sequences so that they follow all the CSF signals. So I will not go into the details. This is case 11, 56-year-old gentleman, known case of GBM, has surgical resection followed by CCRT, and this is a surveillance scan. So this is one of the favorites for everyone. Here you can see that there is a heterogeneous lesion in the left temporal lobe, which is showing significant nodular post-contrast enhancement. And on DWI, it appears bright, but there is no corresponding dropout on ADC mapping. So the differential will include, of course, radiation necrosis versus the tumor recurrence. For that purpose, we can move on to our perfusion sequence. And here on MTT, there is significantly low MTT and significantly reduced cerebral blood volume. So volume is a very good indicator. If there's reduced volume, it is indicative of radiation necrosis. And if it was increased, similar to red, then it was it would have been a tumor recurrence. So this is how perfusion helps in differentiating between necrosis and tumor recurrence. So this is our last case. This is a 30-year-old male who presented with headaches, and I will walk you through the case. You can see that here is a conglomerate enhancing lesion in the right basal ganglia with surrounding edema. It is causing compression of the ventricles. It is not showing any diffusion restriction, and this lesion was biopsied, and the patient was given corticosteroid therapy. After 12 months, the lesion disappeared completely. There was no enhancement, but after 48 months, the lesion reoccurred in the same location. It appears very heterogeneous and there was surrounding edema. On perfusion, there was low CBV, like there was reduced perfusion within the lesion. Again, the patient was treated with corticosteroid and the lesion disappeared. So now answer to the poll is Is the poll visible to everyone?
Yes, the result is just came out.
All right, because I can't see it here. Just a second. I think I'm projecting it again. Now you can answer. All right, great. So of course you will have that in mind, but since we are doing a presentation on non-neoplastic lesions, so this is a tumor factor primary CNS vasculitis. So this can be very confusing as vasculitis or angiitis can present like a tumor. And the biopsy came out to be a granulomatous angiitis, and the patient was treated with steroids and immunosuppressive therapy. So I held back that history. So again, history is also very important. And at times when you are stuck, then biopsy becomes necessary. So here are a few of the cases of primary tumor factor vasculitis or angiitis in which you can see such lobar heterogeneously enhancing lesions with a surrounding edema. And a bit of catch point is that here in the third image, you can see it looks so similar to GBM with ependymal lining involvement. But in reality, these are all tumor factor angiitis. And I think the catch point is that we should look at the leptomeningeal enhancement, ependymal spread, and underlying susceptibility or microhemorrhages within the lesion as well. And of course, in this case, it is a very true mimicker of a tumor, and we need a biopsy for further definitive conclusion.
So, Dr. Shan, how we differentiate it from the lymphoma? Because it's typically enhancing perivascular with edema.
Actually, lymphoma has a very different enhancement. It is a cotton wool appearance, fluffy appearance. It is not that heterogeneous. And in lymphoma, always remember, it never recruits vessels. So you will not get susceptibility or hemorrhage within a lymphoma. So whenever you're thinking of lymphoma, it should be, lymphoma will not cause such effacement as well. So 2 or 3 points, cotton wool appearance, and lack of susceptibility of flow voids within the lesion is very much indicative of a lymphoma. So here is a summary, just to summarize, we spoke about abscesses. I think we are left with 4 minutes. So should I continue with the summary?
Yeah, we can. Meanwhile, if anyone have a question, can please unmute yourself and ask the questions as well. You can also write in the chat box.
All right. So abscess, we know that the hallmark feature is central diffusion restriction and smooth rim enhancement. In invasive fungal infection, you will find the intrinsic T1 hyperintensity and hypointensity on T2 and SWI sequences. In cerebellitis or encephalitis, of course, the history matters, the age matters, and the symmetry also matters. So there will be lack of, there may be diffusion restriction, but it's very rare. And the post-contrast enhancement may show meningeal enhancement as well. On venous hemorrhagic infarcts, there's loss of T2 flow void. Always look at the major sinuses on T2 and flare. And there may be hemorrhage within the infarct bed, and there will definitely be a filling defect on MRV. The tumor factor demyelination, there won't be any diffusion restriction. There will be incomplete rim enhancement, leading edge enhancement, and it will predominantly involve the white matter. The vascular malformations have typical flow voids and tubular serpiginous appearance, and you may find a nidus, arterial and venous supply, and the DVAs can be associated with other malformations like avernoma, and at times they can lead to cortical vein thrombosis and venous hemorrhages. Focal cortical dysplasia, patient undergoing refractory epilepsy because it is involved in the cortex. It results into gray and white matter blurring. There's no diffusion restriction, no enhancement. Ischemic infarct, typically cytotoxic edema, results in bright signals on DWI and corresponding low signals on EDC, and of course it is territorial. Perivascular spaces, they follow CSF signals and may show surrounding gliosis and edema, but of course you need to follow them over time, and if they increase in size or show enhancement, then always biopsy them so that we exclude any low-grade neoplasm. Radiation necrosis, of course, does not show diffusion restriction and no perfusion. This is how you differentiate it from true recurrence. And then you have tumor factor vasculitis or angiitis, which is again not showing any diffusion restriction or perfusion. It is tumor-like. It may show leptomeningeal or ependymal involvement, and biopsy is the way. So take-home pearls are correct differentiation between tumor and tumor-like lesions, which is essential for decision related to treatment and estimation of future prognosis and outcome. The referring physician and radiologist should work together as a team to avoid misinterpretation. If the clinical findings are non-supporting, the radiologist should be aware of the extensive differential diagnosis of tumors and tumor-like conditions and use all the available tools to differentiate between both entities. So the last poll, I will be happy to get a feedback.